Hello, good evening, and welcome once again. In today's lecture, we are going to look at pharmacology, and basically, we are going to talk about drugs which affect the cardiovascular system. Specifically, we are going to talk about antihypertensive drugs. So, before we go into antihypertensive drugs, I would like to give a brief overview of what blood pressure is. When we say blood pressure, there is a normal physiological process in the body, and the blood pressure specifically refers to the force with which blood exerts itself on the walls of the arteries as the heart pumps the blood throughout the whole body. And basically, this is affected by so many factors. The most important ones being the stroke volume, which is the amount of blood which is ejected from the heart per each beat, as well as the heart rate, which refers to the number of times the heart is beating per minute. We also have the peripheral vascular resistance, also determining the blood pressure. We also have things such as the temperature, diet, emotional state, posture, and physical state all coming together to also affect the blood pressure of an individual. We know that in a very cold temperature, blood pressure, tend to increase as compared to a hot temperature when blood pressure falls. This is basically due to vasoconstriction, which we often experience with cold. We also look at emotional state affecting blood pressure in the sense that a very anxious person will always have a very high blood pressure as compared to someone who is relaxed in a relaxed state. Then also posture may also affect blood pressure. When you are lying, your blood pressure may be different. When you are also sitting or standing, your blood pressure may also be different. Physical activities also affect the blood pressure in a way that when someone is exercising, the blood pressure tends to increase as compared to someone who is not exercising. Some medications may also affect the blood pressure. It may cause it to either increase or even drop or fall. This blood pressure is usually measured in millimeters per mercury, and upon measuring, we get two main numbers. For example, as I've indicated over here, we may have the first number being 120, for example, over 80. In this case, the first number being the 120 is referred to as the systolic blood pressure. And when we say systolic blood pressure, it is the pressure which is created when the heart contracts. And the second number being the 80 will be referred to as the diastolic blood pressure. And this is the pressure which is generated inside the blood vessels when the heart dilates or when the heart is at rest. Another important thing that I want us to know is that blood pressure increases with age. And it is interesting to know that about 2/3 of people who are, more than 65 years of age have hypertension. And it's also interesting to know that people with a normal blood pressure at the age of around 50 and 55 years stand the chance of developing hypertension, about 90% lifetime risk of developing hypertension. Now, blood pressure may either be high or may be low. A high blood pressure is referred to as hypertension, and a low blood pressure is referred to as hypotension. A low blood pressure, when we say someone is having a low blood pressure, it occurs usually, when during or after each heartbeat, the pressure which we measure is below normal. And what this means is that the heart itself, as well as the brain and other important organs of the body, such as the kidneys, are all not being perfused or are all not receiving enough blood. And when this happens, the patient may begin to complain of things such as dizziness and also lightheadedness. We shall go more into it later on. When we say hypertension, it refers to a sustained elevation of a resting systolic blood pressure, which is either more than or equal to 140 millimeters per mercury, as well as a diastolic blood pressure, which is more than or equal to 90 millimeters per mercury, or the two of them increasing at the same time. But I like this definition very well, which is a usual blood pressure of 140 over 190 millimeters per mercury or higher, the value of which the benefits of treating outweighs the risk. What are some of the risks of not treating hypertension? The person can get heart attacks. We can also have, cerebrovascular accidents and the strokes. We may also have some dementia. There are a whole lot of complications which may result when an increased blood pressure is not treated. And as you've seen, today's topic is basically on hypertension, so we shall not delve so much into hypertension. We are continuing with hypertension and how we are going to manage it. So basically, hypertension can be either primary, which is also referred to as essential hypertension, or idiopathic. So what this means is the cause is usually not known. And this is the most common form of hypertension that we know. Hypertension can also be with an identified cause, and usually we may have it to be a secondary hypertension. So don't forget, we have a primary or essential hypertension and we have secondary hypertension. Usually, secondary hypertension may be due to chronic kidney disease, sometimes sleep apneas, or even primary aldosteronism. It's very, very important to note these points. And an important thing to also note over here is that hypertension may also develop in pregnancy. In this case, realize that the woman was not pregnant before. The woman was not having hypertension before she got pregnant. She only developed the hypertension when she got pregnant, and usually in the absence of any other sign of preeclampsia, such as proteinuria, such hypertension has minimal effect on pregnancy, and may however indicate a tendency that this woman may develop hypertension in later life. However, if there is present other signs of preeclampsia such as proteinuria, then this woman may need urgent management of the hypertension. Now, we also find out that hypertension is usually found in adults, and usually we have blacks being usually affected with hypertension, usually because of increased stress in the black populace, and also we have it in white and also Mexicans being 28%. Then since it is more in blacks, the mortality and the morbidity are also greater in blacks as compared to the white population. And we can easily diagnose hypertension by checking the blood pressure with a sphygmomanometer. We can also use the ECG to check the blood pressure or to diagnose hypertension, as well as EKG to diagnose hypertension. Now, after diagnosing, how do we treat? Basically, treatment of hypertension involves lifestyle changes. That's the first thing that we can talk about. The next thing we can look at may include drugs, but lifestyle changes may include exercising, checking your diet, and all sort of things. But basically, drugs are also involved or included in the management of hypertension. And the drugs which are used in the management of hypertension may include the diuretics, the beta blockers, the angiotensin converting enzyme inhibitors, also angiotensin 2 receptor blockers, and also the calcium channel blockers. We are going to look at all of these groups of drugs into details. Now, an important thing that I want to draw our attention to as we move forward is that the sympathetic nervous system, as well as the Renal Angiotensinaldosterone system, are the two main physiologic systems which are involved in the development of hypertension. And so I will want us to have an overview of these two major systems, and later on we shall look at how these hypertensive drugs will interfere with each of these processes. So the first system I want us to look at is the Renal Angiotensinaldosterone system. In this system, we shall start from the kidneys. And in the kidneys, we have two main structures we need to talk about. We have the juxtaglomerular apparatus as well as the macula densa cells. Now, this juxtaglomerular apparatus are specialized structures which are formed in the distal convoluted tubules and also in the glomerular afferent arteriole. Now, the main function of this juxtaglomerular apparatus is to regulate blood pressure and also the filtration rate of the glomerulus. The second structure, being the macula densa, are also collection of specialized epithelial cells in the distal convoluted tubules. And what they do is they detect sodium concentration in the fluid in the tubules. So, in response to an elevated sodium, the macula densa cells will trigger the concentration of the afferent arterioles and will try to reduce the flow of blood to the glomerulus, and the glomerular filtration rate will also come down. Now, the juxtaglomerular cells will also come in again, and this, as we've seen already, as I've mentioned earlier, these juxtaglomerular cells are part of the the glomerular afferent arteriole. And so once they come in, or once they sense that the flow to the kidneys or to the arteriole has reduced, they secrete renin. So renin is secreted by the juxtaglomerular apparatus, and this renin will increase, or in turn increases, the blood pressure through this system that we are going to describe, which is the Renal Angiotensinaldosterone system. Now, once renin has been produced, it will act on angiotensinogen, which is produced by the liver, and convert the angiotensinogen into angiotensin 1. Now that we have angiotensin 1, angiotensin converting enzymes, which are found predominantly in the pulmonary endothelium and also some in the kidney, the renal endothelium, will act on the angiotensin 1 and convert it into angiotensin 2. Now, the angiotensin 2 is the one which does the remaining of the work. So, this angiotensin 2 will act now, or have a positive effect on the sympathetic nervous system in the first place. So by so doing, it increases the sympathetic activity of the heart. There will be increased heart rate, as well as there will be increased contractions of the heart. Angiotensin 2 will also act on the renal tubules and cause sodium and chloride reabsorption. And so sodium will leave the tubules back into the blood. Chloride will also leave the tubules back into the blood, as well as water being reabsorbed from the tubules back into the blood. At the same time, potassium will be drawn from the blood back into the tubules to be excreted. This same angiotensin 2 will act on the adrenal cortex and cause the secretion of aldosterone. Aldosterone will also further enhance the reabsorption of water. Now, these mechanisms, once water has been absorbed and sodium has also been absorbed, chloride has also been absorbed, what happens is that it will lead to increased circulatory volume. And once the circulatory volume increases, it is going to increase the cardiac output. And let's not forget that cardiac output is determined by, let's not forget that the systolic blood pressure is determined by the cardiac output. And so once the cardiac output increases, systolic blood pressure will also increase. The angiotensin too will further act on the arterioles to also cause vasoconstriction of the arterioles. And once vasoconstriction occurs, it will also increase the total peripheral resistance. And don't forget that the diastolic blood pressure is also determined by the total peripheral resistance. And so once total peripheral resistance increases, diastolic blood pressure will also increase. Yet, angiotensin 2 will act again on the posterior pituitary gland and cause the release of antidiuretic hormone. This antidiuretic hormone, as the name implies, will also act on the collecting duct and prevent water from being excreted, and so water will further be reabsorbed back into circulation, thereby increasing the circulatory volume and also increasing the cardiac output. And as we've seen already, once cardiac output increases, systolic blood pressure will increase. These are the steps which are involved in elevating the blood pressure when the blood pressure falls. Now, once we've seen this, and once we've had enough circulatory volume, perfusion or blood supply to the kidneys, specifically the juxtaglomerular apparatus, also increases. And once blood supply to the juxtaglomerular apparatus increases, there is a negative feedback mechanism which signals the kidneys or the juxtaglomerular apparatus from releasing enough or releasing further renin. And so renin is no more released again due to this negative feedback mechanism. So this is the system which controls blood pressure in our body. And as we move on with this series of antihypertensives, we shall see that some drugs interfere with each step of this system, as we shall see very soon. The next system I want us to talk about is the sympathetic nervous system and its effect on the heart. As we can see, sympathetic outflow will cause the release of local epinephrine, and these epinephrine will act on the heart, or norepinephrine will act on the heart through the beta 1 receptors, thereby causing a positive inotropic effect on the heart as well as a positive chronotropic effect on the heart. And so once we have a positive chronotropic effect, the rate at which the heart is going to pump will increase, and also the rate or the strength with which the heart muscles, the myocardium, contract will also increase. They all increase to push blood further or strongly out of the heart, thereby increasing cardiac output. And as we've seen already, an increased cardiac output will determine the systolic blood pressure or increase the systolic blood pressure. Similarly, we may also have systemic epinephrine and also systemic norepinephrine going through the same route and affect the heart to increase the heart rate as well as the myocardial contractility. And also these systemic norepinephrine and epinephrine will also act on the arterioles to cause systemic vasoconstriction through the alpha 1 receptors. So basically, This is how the systemic or the sympathetic nervous system affects, the regulation of the heart, as well as how the heart works to increase the blood pressure. Now, we shall see very soon that in each of these steps, we may have antihypertensives which will block these steps and prevent the heart from either having an increased heart rate or having an increased strength of contraction, thereby reducing the blood pressure. We may also see that we may have drugs which will prevent or which will block these alpha receptors and prevent systemic vasoconstriction, thereby reducing the blood pressure. So when we move on to the drug classification, the main drugs which are used in the management of hypertension, the first one we can talk about are the drugs that alter the sympathetic nervous system. And under these, we have the centrally acting sympathoplegic drugs, and the common ones being the methyl dopa and clonidine. And what these ones do is they work through the alpha 2 agonist. By so doing, they inhibit the sympathetic activity in the brainstem, thereby helping to reduce the blood pressure. Now, methyl dopa is usually helpful or very effective in pregnancy, a very good drug used in pregnancy to control blood pressure. And clonidine, usually we use it for third or fourth line medication in the management of hypertension when all other antihypertensives have failed. This clonidine crosses the blood-brain barrier and also acts in the hypothalamus to induce a decrease in the blood pressure. Now, we also have the ganglionic blocking drugs, and examples over there, the hexametonium. We shall go deep into all of these drugs one by one and see how they all work, their mechanism of action and their pharmacologic effect. Then we also have the adrenergic neuron blocking drugs, the common one being the reserpine. We also have the guanethidine. And reserpine works by inhibiting the uptake of norepinephrine. And once norepinephrine is not taken up by the storage vesicles, it leads to the depletion of catecholamines as well as serotonin. And so when we don't have catecholamines and serotonin from both the central and peripheral terminals of the axons, it leads to the decrease in the heart rate as well as a decrease in the force of contraction of the heart. And also we also realize that there is a decrease in the total peripheral resistance, thereby reducing the blood pressure. Then we can also talk about the adrenoceptor blocking drugs. And under these adrenoceptor blocking drugs, we have basically the alpha receptor blockers. We also have the beta receptor blockers. So as you saw in the previous diagram, we saw that the sympathetic nervous system was affecting the heart through the alpha receptor blockers as well as the beta receptor blockers. And so these drugs basically will inhibit or will prevent the action of the sympathetic nervous system on the heart. And so alpha blockers will prevent the effect of epinephrine and norepinephrine on the heart. By so doing, they are going to decrease the heart rate, also decrease the contraction of the heart, and this will lead to a decreased cardiac output as well as a decreased blood pressure. Also, the that was for the beta blockers. The alpha blockers will also work through the alpha 1 receptors and prevent systemic vasoconstriction. So basically, alpha blockers will prevent systemic vasoconstrictions, whilst the beta blockers will prevent the effect of epinephrine and norepinephrine on the heart. It will lead to a decrease in heart rate as well as a decrease in the force of contraction of the heart, leading to a decreased cardiac output and fall in the blood pressure. Now, the next drug, and these are examples of these drugs. And the alpha blockers, we have the prazosin, and usually we call them the zosins, the prazosins, the terazosins, etc. Then we also have the beta blockers, examples being the atenolol, the esmolol, the timolol, as well as the propranolol. We shall go deep into all of these drugs and see how they work. Then we also have the alpha and beta blockers, both alpha and beta blockers, typically example being the labetalol. Now we also have another class of drug being the direct renin inhibitors, and these direct renin inhibitors, what they do is they prevent the interaction between the renin and the angiotensinogen, which is being released from the liver, and so they cannot interact for us to get angiotensin 1. So we have drugs which will block these processes also from happening, and a common amongst these classification is what we call the aliskiren. The next class of drugs we can talk about are the nitrates, and the nitrates basically what they do is they induce venodilation. They work on the the venous system, causing venodilation, and once there is dilation of the veins, venous returns will decrease, and once venous returns decreases, the cardiac output will also decrease. And as we know, once cardiac output decreases, then systolic blood pressure will also fall. A typical example of these nitrates are the isosobide mononitrate and also isosobide dinitrate. The next class of drugs we can use in the management of hypertension are the calcium channel blockers. And basically, we have two types of these. We have the dihydropyridines and the non-dihydropyridines. The dihydropyridines basically work by blocking the systemic vasoconstriction. And examples are the drugs which ends with pine, or pin. The nifedipine, the nicardipine, these amlodipine. These are the drugs which are grouped under the dihydropyridines. Now, the non-dihydropyridines also work by reducing the heart rate as well as the contractility of the heart. And the main examples we have are the diltiazem and the verapamil. The next class of antihypertensives that we can talk about are the angiotensin blockers. And under the angiotensin blockers, we have the angiotensin receptor blockers, that is the angiotensin 2 receptor blockers, as well as the angiotensin converting enzyme blockers. When we talk about the angiotensin 2 receptor blockers, they are the drugs which will prevent the effects of angiotensin 2, as we saw in the diagram earlier on. And so the increased heart rate, which is caused by angiotensin 2, the increased contractility, which is caused by angiotensin 2, as well as the reabsorption of water, sodium and chloride, are all going to be inhibited. And so this is when we use angiotensin 2 receptor blockers. Then angiotensin converting enzyme inhibitors also block the conversion of angiotensin 1 to angiotensin 2. Then we have another drug which are called the competitive inhibitors of angiotensin 2, example being the serralazine. Now, the next class of drug we can talk about are the diuretics. And diuretics basically are going to prevent sodium and water reabsorption in the kidneys. We shall look at them one by one and see how each of them work. Then we also have the last group of drugs being the direct acting vasodilators, and these ones work almost the same way like the nitrates. So they dilate the vessels, they dilate the veins, prevent they dilate the veins and reduce they reduce the amount of blood which is going back to the heart, which is the venous returns, and also they prevent or they reduce cardiac output, hence reducing the blood pressure. So In the last slide, I decided to bring all of these drugs together since there are a lot of drugs, so many classifications. We have these simple, algorithm of it. So over here we have the class of drugs, their common surfaces, common examples of such drugs, and also the side effects that we can have when we take these drugs. And so the first one being the ACE inhibitors. They are the angiotensin converting enzyme inhibitors. Usually they end with pro, and examples are the lisinopril, the fosinopril, the enalapril, and basically their side effects will be the dry cough and the renal dysfunction. Also, we look at the thiazide diuretics. They don't have any suffix, as well as the loop diuretics. They don't have any suffix. But these are some of the examples that we have, and their side effects being hypokalemia, hyponatremia, renal dysfunction. So we are going to pick each of these drugs one by one and look at it into details, their mechanism of action, their pharmacological effect, and also when to use them clinically, and when they are contraindicated to be used. So we also have the dihydropyridines, which ends with pain, such as the amlodipine, the nicardipine, the nifedipine, and basically their major side effects are constipation and also lower extremity edema. Then we also have the angiotensin receptor blockers, which are usually called the SARTANs. Example being the losartan, the valsartan, the ipsartans. Then we also have the beta blockers, always end with lol, such as labetalol, esmolol, propranolol, and their major side effect is decreased myocardial contractility, bradycardia, and also sexual dysfunction, as well as depression. Then we have the alpha blockers, always ending with zosins or osins, such as the terazosins, the prazosins, and their major side effect being orthostatic hypotension. So this is the end of the introductory lecture to antihypertensives. And if this is the first time you are watching this channel, I would advise and encourage you to subscribe to Bright Medical Lectures for the upcoming videos, and help us to develop and also to improve. The next video is going to be on the specific antihypertensives and how they work. Thank you very much for your time, and I hope it helps. Thank you. Bye-bye.